Welcome to the Historical Podcast. Today we will talk about medieval medicine. The study of medieval medicine offers a fascinating glimpse into a world where healing practices were deeply intertwined with ancient philosophies, religious doctrines, and the pragmatic realities of daily life. Spanning from the 5th to the 15th century, the Middle Ages were a period of immense transformation across Europe, marked by the fall of the Western Roman Empire and the subsequent rise of new societal structures. Understanding medicine during this era requires moving beyond simplistic notions of a dark age and appreciating the complex interplay of inherited knowledge, spiritual beliefs, and practical innovations that characterized healthcare. In the early Middle Ages, following the collapse of the Roman Empire, much of the standard medical knowledge was precariously preserved in surviving Greek and Roman texts. These invaluable manuscripts found refuge primarily within monasteries, where monks diligently copied and revised them, acting as custodians of ancient wisdom. The decline of the classical civilizations had indeed led to a regression in broader artistic, cultural, and scientific outputs compared to both preceding and succeeding eras. This reliance on monastic preservation highlights a significant aspect of knowledge transmission during times of societal fragmentation. The fragility of intellectual heritage. The very act of preserving these texts, while crucial, also meant that the Church, as the primary institution of learning, exerted considerable influence over which ideas were propagated and how they were interpreted. This custodial role, while vital for the survival of medical knowledge, also shaped its evolution, often prioritizing theological compatibility over empirical inquiry. Despite the popular misconception of the Middle Ages as a period devoid of medical progress, a closer examination reveals a different reality. This era, often popularly mischaracterized as a dark age for intellectual and scientific advancement, in fact witnessed a nuanced and evolving medical landscape. Far from being a static era of ignorance, this epoch saw considerable development in fields such as surgery, medical chemistry, and anatomical dissection. These advancements were not sudden leaps, but rather a gradual and persistent progression. The period established foundational practices, transitioning from informal apprenticeships to structured university education, and from oral traditions to the systematic documentation of medical texts. This slow but steady accumulation of knowledge and refinement of techniques laid essential groundwork for the more dramatic scientific discoveries that would follow in subsequent centuries. The prevailing historical narrative sometimes overlooks these incremental yet crucial steps, which demonstrate a continuous human endeavor to understand and alleviate suffering. Even amidst societal upheaval and limited scientific tools, medieval medicine, therefore, was a dynamic blend of ancient theories, spiritual influences, and practical, often empirical, observations, reflecting the multifaceted challenges and adaptations of the time. Part 1. The Philosophical and Spiritual Underpinnings of Health. Chapter 1.1. The Enduring Humors, Body, Balance, and Disease. The bedrock of medieval medical philosophy was the humoral theory, a concept that profoundly shaped understanding of the human body, health, and disease for over a millennium. This influential framework originated in ancient Greek medicine, most notably with Hippocrates around the 5th century BC. Hippocrates is often credited as the father of medicine for his pioneering work in developing a systematic approach to clinical practice, which emphasized natural causes of disease rather than supernatural explanations. The humoral concept was subsequently refined and widely popularized by Galen of Pergamon, 129 to 201 AD, whose extensive writings integrated the theory into a comprehensive philosophical system that dominated both Eastern and Western medical thought for centuries. Interestingly, the fundamental notion of humors, or vital bodily fluids, may have even earlier roots in ancient Egyptian or Mesopotamian medicine, and similar theories involving 3 or 4 humors were present in Indian Ayurvedic medicine. The widespread adoption of a humoral or balance concept across diverse ancient cultures points to a fundamental human drive to systematize observable phenomena, such as bodily fluids and temperaments, into a coherent framework for understanding health and disease. This common cognitive strategy, in the absence of a germ theory, sought internal, observable causes for illness, highlighting a universal human attempt to impose order on the seemingly chaotic experience of sickness. According to this theory, the human body was composed of four primary vital fluids: blood, phlegm, yellow bile, and black bile. Each of these humors was believed to possess specific qualities and associations, creating a complex web of interconnectedness within the body and with the external world. Blood, for instance, was considered hot and wet, associated with the element of air, and a sanguine, optimistic, courageous temperament. Phlegm was cold and wet, linked to water and a phlegmatic, calm, placid disposition. Yellow bile, hot and dry, corresponded to fire and a choleric, irritable, passionate nature. Finally, black bile, cold and dry, was associated with earth and a melancholic, depressive, introverted temperament. Medieval beliefs also assigned specific organs to produce or store these humors: the liver for blood, the brain and lungs for phlegm, the spleen for yellow bile, and the gallbladder for black bile. The state of perfect health, known as eucrasia, was believed to result from a harmonious balance of these four humors in both quantity and strength. Conversely, any imbalance, termed dyscrasia, was considered the direct cause of all diseases and mood disorders. For example, an excess of phlegm was thought to cause lung diseases, while too much blood could lead to fever. The primary objective of medieval medicine was, therefore, to restore this delicate humoral equilibrium. A significant implication of humoral theory was its comprehensive approach to the patient. It linked physical health not only to internal bodily fluids, but also to mental state, temperaments, and even external environmental factors like seasons and winds. This meant that diagnosis and treatment were not merely focused on alleviating a specific symptom, but on understanding the patient as a holistic entity within their broader environment. As one source notes, humoral theory forced physicians to consider patients as a whole during diagnosis and treatment. While the scientific basis of this theory is now dated, its enduring legacy lies in fostering a patient-centered perspective that viewed the individual as a complex system influenced by multiple interacting factors. This comprehensive, albeit flawed, model for understanding the interplay of body, mind, and environment represented a significant intellectual achievement for its time. To aid in understanding the core components of this foundational theory, the following table summarizes the four humors and their key associations. Blood was associated with the element air. It was believed to have hot and wet qualities, and the corresponding temperament was sanguine. According to medieval belief, the liver was the organ linked to blood. Phlegm was connected to the element water. It was thought to possess cold and wet qualities, and the related temperament was phlegmatic. The brain and lungs were considered the associated organs. Yellow bile was linked to the element fire. It was described as having hot and dry qualities, and the temperament associated with it was choleric. The spleen was believed to be the organ influenced by yellow bile. Black bile corresponded to the element earth. It was believed to have cold and dry qualities, and its temperament was known as melancholic. The gallbladder was considered the related organ. Chapter 1.2: Faith, Sin, and Suffering. The Church's influence on medicine. The Roman Catholic Church was the preeminent institution in medieval Europe, wielding immense power that extended far beyond spiritual matters to profoundly influence daily life, including the understanding and practice of medicine. A central tenet propagated by the Church was that illnesses were often divine punishments for sins committed or, alternatively, trials of faith sent by the devil. This theological explanation reinforced the Church's authority, framing suffering as a normal and even expected part of the human condition. Consequently, many people believed that leading a righteous life, characterized by regular prayers, confessions, and offering tithes, would serve as a protective measure against illness. This perspective effectively moralized disease, placing a significant psychological and social burden on the sick, who might experience guilt or shame in addition to their physical ailments. This also shifted the focus of healing from purely physical interventions to spiritual appeasement, directly influencing the types of treatments sought and potentially slowing the adoption of more empirical approaches. Despite this theological framework, the Church played a complex and dual role in the development of medieval medicine. On one hand, It was instrumental in preserving and disseminating medical knowledge. Monasteries and convents emerged as vital medical centers, providing essential care to communities, often under the supervision of religious orders like the Benedictines and Dominicans. Monks and nuns served as primary caregivers, meticulously copying and revising ancient medical texts, including the works of Galen and Hippocrates, thereby safeguarding a vast body of knowledge that might otherwise have been lost during periods of societal instability. These monastic communities also cultivated herb gardens, specifically for medicinal purposes, contributing to the practical application of remedies. However, the Church's role was not without its limitations. While it preserved knowledge, this preservation often came with a strong endorsement of specific authors like Galen, whose theories were deemed compatible with Christian ideology due to his belief in a higher power creating human life. This inadvertently restricted the evolution of medical thought by canonizing certain texts and discouraging any deviation or critical inquiry. The Church's control over medical education meant that new ideas were rarely introduced in universities, and questioning established beliefs was often met with resistance. A notable example of this restrictive influence was the Church's ban on human dissection for anatomical study, based on the belief that the body should remain whole for resurrection. This prohibition significantly hampered the advancement of anatomical knowledge and, consequently, surgical practices. Historical records even show instances, such as the arrest of the 13th century monk Roger Bacon, for daring to suggest that physicians should not blindly trust old medical textbooks. This illustrates a fundamental paradox. The institution responsible for safeguarding intellectual heritage simultaneously acted as a primary barrier to its empirical and scientific advancement, prioritizing dogma over observational discovery. Religious healing practices were deeply integrated into the fabric of medieval medical care. Treatments frequently included pilgrimages to holy sites, fervent prayers, and the touching of sacred relics. Sacramentals, such as holy water and sacred images, were believed to invoke divine intervention, offering comfort and solace to the afflicted, and even warding off malevolent forces thought to cause illness. Physicians themselves often combined their medical knowledge with religious practices, sometimes consulting both medical texts and religious calendars when planning treatments. While these spiritual interventions may not have offered a scientific cure in the modern sense, they provided immense psychological and social support in an era with limited understanding of disease. This highlights that healing, in the medieval context, encompassed more than just physical recovery. It profoundly addressed spiritual and emotional well-being, offering comfort and hope when scientific solutions were unavailable. This vital distinction underscores the holistic, albeit non-scientific, approach to human suffering prevalent in the Middle Ages. Chapter 1.3: Celestial and Earthly Signs, Astrology, Miasma, and the Doctrine of Signatures. Beyond the direct influence of the Church and the humoral theory, medieval medicine was also shaped by a range of other philosophical and observational beliefs, including astrology, miasma theory, and the doctrine of signatures. These systems provided frameworks for understanding the causes of disease and guiding treatment decisions in a world where scientific understanding was nascent. Astrology played a considerable role in medieval medical practice, serving as a diagnostic tool and a guide for timing medical interventions. It was widely believed that celestial bodies exerted influence over the balance of the four humors within the human body. Physicians would consult the appearance of the sky for diagnostic purposes and use the positions of planets to determine the most auspicious time for administering treatments, such as bloodletting. Some practitioners even utilized complex medical charts to identify treatments to avoid for individuals born under specific astrological signs. In the absence of germ theory or advanced diagnostic instruments, astrology offered a comprehensive and seemingly logical framework that connected the macrocosm of the heavens to the microcosm of the human body. This approach was not merely superstition, but an attempt to discern order and predictability in a world where disease often appeared random and uncontrollable. It provided a scientific basis, by their contemporary standards, for guiding interventions, offering practitioners and patients a sense of control and a rationale for medical decisions. Another prevalent theory of disease causation was the miasma theory, which posited that illnesses were caused by bad air or noxious fumes emanating from decaying matter. While scientifically incorrect, this belief inadvertently led to certain public health practices that had beneficial outcomes. For instance, efforts to remove rotting animal carcasses, maintain cleaner public toilets, and use aromatic herbs like lavender, often carried in decorative pomanders, to purify the air, were all driven by the miasma theory. Local authorities frequently implemented public health measures based on this understanding, such as fining people for dumping rubbish and banning butchers from working on the streets in cities like London. The observation that these actions sometimes reduce disease transmission, even if the underlying mechanism, germs, not smells, was unknown, demonstrates a significant aspect of medieval pragmatism. It illustrates that even flawed scientific theories can drive practical actions that, by chance, improve public health. This highlights that progress is not always contingent on a perfect scientific understanding, but can emerge from a combination of observation and a desire to mitigate perceived threats, showcasing the adaptive nature of medieval societies in the face of widespread illness. Finally, the doctrine of signatures offered a unique intersection of theological belief and rudimentary empirical observation. This doctrine, widely adopted by Christian philosophers and medics, held that God, in His benevolence, would provide a cure for every illness, and that the intended remedy would be subtly indicated through the physical appearance or signature of plants and minerals in nature. For example, the eyebright flower, with its small, eye-like petals, was believed to be effective for treating eye ailments. Similarly, the skullcap plant, whose seeds were thought to resemble a human skull, was used for headaches. This approach was more than simple superstition. It represented an attempt to find divine clues embedded within the natural world. It exemplifies how medieval thought integrated spiritual explanations with observable phenomena, forming a coherent worldview where God's design was perceived in the physical attributes of natural elements, thereby guiding their medicinal application. This demonstrates a pre-scientific epistemology where divine intent and natural form were inextricably linked in the quest for healing. Part 2. The practitioners and their practices. Medieval medicine was a diverse field, populated by a range of practitioners with varying levels of training, social status, and scope of practice, from the highly educated physicians serving the elite to the local folk healers tending to the common populace. Healthcare was a multi-tiered system reflecting the social hierarchy of the age. Chapter 2.1. The learned and the elite. Medieval physicians. Medieval physicians represented the pinnacle of formal medical education and were considered the intellectual elite of the medical profession. Their training was rigorous and extensive, typically undertaken at universities that began to formalize medical studies around the 11th and 12th centuries. Early and prominent institutions for medical learning included Bologna, Paris, and Oxford. A physician's education could span anywhere from 7 to 10 years, culminating in a demanding process where students had to demonstrate their mastery by reciting, lecturing, and debating the contents of their studies. The curriculum was heavily theoretical, rooted deeply in the ancient texts of Hippocrates and Galen, which were often approved and even mandated by the Church. This emphasis on classical authority, while providing a foundational body of knowledge, also meant that practical experience was often limited. Physicians typically did not engage in direct patient treatment themselves. This was particularly true for those who were also clergymen, as church regulations generally prohibited clergy from involvement in procedures that shed blood. This created a significant disconnect between theoretical knowledge and hands-on patient care. A highly educated class of medical professionals existed, yet their training was largely divorced from the practical realities of treating illnesses. This structural separation helps explain why other, less formally educated practitioners, such as barber surgeons, apothecaries, and folk healers, played such a vital and direct role in everyday medicine, particularly for the common populace. It also highlights a systemic barrier to empirical advancement within the medical elite, as direct observation and experimentation were often secondary to textual authority. The primary tools of the medieval physician were diagnosis and prescription. Largely relying on non-invasive methods, Key among these were uroscopy and pulse diagnosis. Uroscopy, the visual examination of urine, was a predominant diagnostic method, so central to a physician's practice that the specially shaped glass flask used, called a matula, became a recognizable symbol of the medical profession itself. Physicians meticulously analyzed the color, odor, and sometimes the composition of a patient's urine, believing that different characteristics corresponded to specific illnesses or humoral imbalances. Diagnostic charts, often known as uroscopy wheels, were utilized to connect specific urine colors to particular diseases. John Zacharias Actuarius, 1275 to 1328, a chief physician to the Byzantine Empire, further advanced this practice by focusing on urinary sediments and their diagnostic significance, observing that heavy sediment might indicate lower body ailments, while bubbles on the surface could suggest issues related to the head. The practice was sometimes even performed remotely, with patients sending urine samples to their physicians. The act of diagnosis itself often took on a performative quality, with physicians dramatically holding the matula up to the light and thoughtfully pondering their conclusions in front of the patient, their family, and servants. This suggests that the diagnostic process served a social function beyond mere medical assessment, reinforcing the physician's status and expertise, especially given the limited scientific understanding of the time. This intertwining of medical practice with social rituals was crucial for maintaining professional authority. The following table illustrates some key urine characteristics and their perceived diagnostic meanings in medieval uroscopy. Clear urine was sometimes interpreted in medieval times as a sign of pregnancy, or in other cases as a sign of being a constant virgin, especially if the urine appeared wan and extremely calm. Thick urine was believed to indicate no conception, particularly if clear urine was thought to signify pregnancy. It could also mean the woman was considered corrupt. Sweet-tasting urine was linked to diabetes, a condition formally recognized in the 17th century, though the concept likely existed earlier. Brownish-tinted urine was interpreted as a sign of jaundice. Red or foamy urine was thought to indicate kidney disease. Urine containing pure or unclotted blood accompanied by pain was believed to point to kidney problems, such as stones or infections. Lead-colored urine was associated with miscarriage. Urine with heavy sediment was believed to reflect lower body ailments. Bubbles on the surface of urine were thought to signal head-related issues. Pulse diagnosis was another crucial method for physicians. Physicians, particularly influential figures like Avicenna, 981 to 1037 CE, developed intricate systems for categorizing the pulse based on various characteristics, including its size, duration, temperature, compressibility, fullness, equality, and regularity. Avicenna even drew comparisons between pulse rhythms and musical rhythms, a belief that was widely held throughout the Middle Ages. His detailed observations brought him remarkably close to understanding various arrhythmias based on pulse characteristics, describing pulses akin to those observed in arterial and ventricular arrhythmias in modern medicine. Moses Maimonides, 1135 to 1204 CE, also contributed to this field, correlating arterial pulse rhythm with the severity of illness, noting that more severe conditions often presented with more irregular pulses. For centuries, palpation of the pulse served as the primary window into the heart, providing critical diagnostic and prognostic information. The scope of practice for these university-trained physicians was largely confined to diagnosis and the recommendation of treatments, which were then typically executed by other practitioners. They prescribed herbal remedies, which apothecaries would then prepare. Due to their extensive training and specialized knowledge, physicians were exceedingly expensive, making their services accessible almost exclusively to royalty and the wealthy elite. Furthermore, most physicians resided in towns, meaning that people living in rural villages rarely, if ever, had access to their expertise. This economic barrier meant that the most formally advanced medical knowledge of the time was a luxury, largely unavailable to the majority of the population. This highlights how socioeconomic status fundamentally dictated access to healthcare and, consequently, health outcomes, creating a starkly tiered medical system where the poor had to rely on less formal and often less effective healing methods. The best available care was unequivocally a privilege, not a universal right. Chapter 2.2: The hands-on healers, barber surgeons, apothecaries, and folk healers. While physicians occupied the academic and theoretical sphere of medieval medicine, the practical, hands-on aspects of healing were largely carried out by a diverse group of practitioners, each with their own distinct roles, training, and limitations. These included barber surgeons, apothecaries, and various forms of folk healers. Barber surgeons were among the most common medical practitioners in medieval Europe, embodying a blend of grooming services and practical surgical skills. This dual role stemmed from the fact that barbers, already adept with sharp razors, were presumed to be skillful in any procedure involving cutting the skin. Their responsibilities ranged from cutting hair and pulling teeth to performing minor surgeries and even amputations. The association between barbers and surgeons became formalized after a papal decree in 1215 prohibited clergy from shedding blood, leading to the transfer of surgical practices to barbers. Barber surgeons were often charged with caring for soldiers during and after battle, highlighting their crucial role in military medicine. Their training was primarily through apprenticeships, where they learned by doing, often starting with menial tasks and gradually progressing to more complex procedures like bloodletting and even keeping leeches. Common surgical procedures included lancing boils, extracting arrowheads, cauterizing warts, removing cysts, and setting broken bones. More advanced procedures, such as amputations, were performed without anesthetic, and instruments were not sterilized, leading to extremely high rates of blood loss, shock, and fatal post-operative infections. The traditional red and white barber's pole, still seen today, is said to symbolize this historical practice, the red representing blood and the white representing bandages. Despite the primitive nature of their techniques and the high risks involved, barber surgeons were indispensable for the common person, as university-trained physicians considered such manual work beneath them. Apothecaries served as the predecessors to modern pharmacists and, in many ways, general practitioners, particularly for the common populace. They were trained and skilled in formal medicine, specializing in the preparation and dispensing of herbs and medicines. Historically, their profession dates back to ancient Babylon and Egypt, with detailed medical texts outlining prescriptions and compounding instructions. In medieval towns, apothecaries were often the best option for obtaining medicine, as they studied plants for years and sometimes cultivated their own medicinal gardens. Apothecaries prepared a wide array of remedies, often based on trial and error due to limited understanding of why certain treatments worked. These recipes frequently included herbs, such as catnip, chamomile, fennel, mint, garlic, witch hazel, minerals, and even animal parts like meats, fats, and skins. These ingredients were ingested as powders, mixed with honey, applied as external pastes, or used in aromatherapy. While some of their remedies, like chamomile, still find use today, others, such as urine, fecal matter, earwax, human fat, and saliva, are now considered ineffective or unsanitary. Beyond medicinal preparations, apothecaries also diversified their income by producing and selling cosmetics, perfumes, shampoos, soaps, cleaning agents, and clothing dyes. Their shops were designed to attract customers, often displaying their wares in elaborately decorated jars, which lent prestige to their craft. As physicians were expensive and served primarily the elite, apothecaries filled a crucial role in providing healthcare access to the majority of the population. Folk healers, often referred to as wise women or leeches, a term for lay practitioners, comprised a significant segment of medieval healthcare, particularly in rural areas where formal medical practitioners were scarce. Their training was largely practical and informal, passed down through generations, often within families or specific genders. These healers relied heavily on observation, traditional knowledge, and local remedies. Their practices often blended herbal medicine with superstitious elements. Herbal remedies were central, with healers knowing which herbs, flowers, trees, and plants possessed healing powers or could ward off evil influences. Compendiums like Bald's Leech Book, circa 900 AD, included citations from classical works alongside local folk remedies. However, Their methods also incorporated charms, magic stones, and religious rituals to drive out evil spirits. For example, buttercups worn around the neck were thought to cure insanity, and specific herbs picked at certain times, e.g., facing south at sunrise, were believed to be more potent. While some of the herbal knowledge had genuine efficacy, e.g., laxatives, diuretics, other remedies were based on sympathetic magic, e.g., herbs shaped like body parts for corresponding ailments, or outright superstition, e.g., swallowing a spider for ague, rubbing goose droppings for baldness. Despite the lack of formal regulation, many folk healers were highly respected in their communities for their ability to care and heal. Chapter 2.3 Other Vital Roles: Monks, Nuns, Midwives, and Nurses. Beyond the primary medical roles, other individuals and groups played indispensable parts in the medieval healthcare system, often bridging the gap between spiritual care and practical healing. Monks and nuns were central figures in early medieval medicine, particularly within the confines of monasteries. In the early medieval centuries, monks were primarily responsible for copying and preserving ancient medical manuscripts, including the works of Hippocrates and other Greek or Latin medical writers. There is evidence that they actively practiced the medical knowledge they acquired through their scribal work. Each monastery maintained an infirmary, not only for its ailing and aged members, but also to provide medical aid to the poor, travelers, and pilgrims who sought refuge or care. Some monks gained such a reputation as skilled healers that lay patients specifically sought them out. In certain instances, the increasing demand for care from outsiders led to the development of hospitals separate from the monastic infirmaries. Monastic hospitals, like the Hôtel Dieu in Paris, founded in the 7th century, and the Great Hospital in Norwich, 11th century, were significant institutions, providing care for the sick and poor, often run by religious orders. These hospitals prioritized the care of the soul, seeing illness as a divine punishment, and thus emphasized rest, prayer, and basic hygiene rather than aggressive curative treatments. Monks and nuns, though possessing only basic medical knowledge, were often the most qualified caregivers available. Driven by the Christian duty to care for the sick and poor, midwives occupied a unique and largely female-dominated space in medieval medicine, primarily responsible for care during pregnancy, childbirth, and the immediate postpartum period for both mother and newborn. Given the limited study of women's health issues in ancient Greek and Roman medical texts, it was generally assumed that such matters were best handled by women themselves. This perception allowed women to continue the practice of midwifery with relatively little male interference throughout much of the medieval era. Midwives typically learned their craft through practical, hands-on experience, often apprenticing with older, more experienced midwives or by observing births from a young age within their communities. Formal training was not generally required, and most midwives were illiterate. Their tools were basic, including scissors, linens, trays, baskets, and birthing stools. They provided crucial support during labor, identified signs of imminent delivery, and assisted with the birth, sometimes applying ointments or exerting pressure on the abdomen to facilitate delivery. Midwives were esteemed members of society, recognized as the sole female professionals, requiring qualified training in their specific domain. While male physicians generally avoided childbirth, there is some evidence that male medical theorists began writing manuals for midwives in the late Middle Ages. Though these often contained outdated information, nurses in the medieval period, much like midwives, were predominantly women, often associated with monastic orders. Early hospitals, many attached to monasteries, relied on monks and nuns to care for the sick and injured, and to provide housing for refugees and lepers. Medieval nurses had a broader range of duties than many modern nurses, encompassing basic patient needs, spiritual support, and general upkeep of the infirmary. The Church's teaching that caring for the sick was a Christian duty meant that nursing was often seen as an act of religious devotion, with some believing that the unpleasantness endured would enrich their souls. The master of the infirmary, often a monk, oversaw patient treatment and medical care, combining religious duties with practical responsibilities. These could include personally serving meals, sprinkling holy water, and reciting prayers over beds, checking on patients at night, and even preparing the dead for burial. During major epidemics like the Black Death, women from all socioeconomic groups stepped forward to care for the sick, and noble-born women who nursed the poor were sometimes revered as nursing saints. The concept of nursing as a distinct profession focused on patient care was deeply infused with religious charity and communal responsibility throughout the Middle Ages. Chapter 2.4: Surgical Innovations and Limitations. Medieval Surgery, though often perceived as crude by modern standards, saw significant practical advancements and a gradual lessening of the taboo surrounding dissection, particularly in the later centuries. Surgical procedures and techniques were often performed by barber surgeons, who, as previously discussed, were the primary practitioners of physical interventions. Common procedures included setting broken bones, lancing boils, extracting teeth, and performing minor operations for hernias, gallstones, and even cesarean sections. While physicians generally avoided manual surgery, considering it a lower-class trade, some university-trained surgeons did emerge, particularly in Italy. High medieval surgeons like Mondino de Liuzzi pioneered anatomy in European universities and conducted systematic human dissections, marking a shift towards more empirical understanding. Notable figures like Roger Fregari of Parma, circa 1180, and Theodoric Borgognoni, 1250 to 1265, composed treatises on surgery, documenting and promoting innovations. Borgognoni's Chirurgia advocated for early forms of antiseptic practice in wound treatment and the use of surgical anesthesia, often a mixture of opiates and herbs. Wine was commonly used as an antiseptic for washing wounds, an empirical observation that provided some benefit despite the lack of understanding of germ theory. Surgeons also employed ointments and cauterization for wound care. Medieval surgeons became adept at external surgery, treating eye cataracts, ulcers, and various types of wounds, and were even capable of surgically removing bladder stones. Trepanning, the practice of cutting a hole in the skull to relieve pressure or release evil spirits, was also performed, with evidence of patient survival in prehistoric examples. Anesthesia and pain management relied on substances like opium and alcohol to dull pain during surgery. The mixture of opiates and herbs mentioned by Borgognoni suggests an early, albeit rudimentary, attempt at general anesthesia. However, these methods were often inconsistent, and many procedures were performed with minimal or no effective pain relief. Dissection and anatomical knowledge saw a slow but significant progression. While the Church generally banned human dissection, considering it a violation of the body's integrity for resurrection, exceptions and advancements did occur. Dissection for medical purposes became more prominent around 1299, particularly in Italy. The University of Bologna was a pioneer in introducing anatomical dissection into educational settings. The first recorded autopsy dates from 1286. The 14th century saw a significant spread of dissection and autopsy in Italy, adopted by medical faculties and colleges for physicians and surgeons alike. Despite the strong influence of Galenic anatomy, which sometimes led practitioners like Mondino de Liuzzi to try and fit human findings into Galen's animal-based descriptions. These systematic human dissections marked a crucial step towards a more accurate understanding of human anatomy. Venice, in particular, defied the Church's ban on dissection, contributing to its doctors being among the best in Europe. Risks and challenges in medieval surgery were substantial. The lack of understanding of germ theory meant that surgical instruments were not sterilized, leading to rampant post-operative infections that were often fatal, even from minor procedures. Many saw pus as a good sign that the body was ridding itself of toxins, further exacerbating the problem of infection control. Blood loss and shock were also major concerns, especially during amputations, which, though performed quickly, carried immense risk. The high mortality rates associated with surgery underscore the primitive stage of the craft, despite the ingenuity and bravery of its practitioners. Chapter 2.5: The Influence of Islamic Medicine. The medieval Islamic world played an indispensable role in the advancement of medicine, not only through its own original discoveries, but also by preserving, translating, and elaborating upon the medical knowledge of ancient Greek, Roman, and even Indian civilizations. This rich tradition profoundly influenced Western European medicine, particularly from the 11th century onwards. Preservation and translation of ancient texts. Islamic scholars meticulously translated a vast corpus of Greek medical texts into Arabic, including the works of Hippocrates, Galen, Aristotle, and Dioscorides. This monumental translation movement ensured the survival of classical knowledge that might otherwise have been lost, especially during the early Middle Ages in Western Europe, when much of this knowledge was inaccessible. These Arabic translations became the conduit through which classical pharmacological and medical knowledge flowed back into Europe during the 12th century Renaissance. Original contributions and key figures. Islamic medicine was far from a mere repository of ancient knowledge. It was a vibrant field of original research and innovation. Abu Bakr al-Razi, d. 925 AD, was a Persian physician who made significant contributions. He is credited with pioneering ophthalmology, identifying fever as a defense mechanism against disease, and even discovering allergic asthma. As a pharmacist, he introduced mercurial ointments and invented various medical devices. His works, alongside Ibn Sina's, were extensively studied in Islamic medical schools and later in Europe. Ibn Sina, Avicenna, 981 to 1037 CE, was another Persian polymath whose influence on medieval European medicine was profound. His 5-volume textbook, The Canon of Medicine, Kitab al-Canon fi al-Ib, became essential reading in medical schools across Europe, including Leuven and Montpellier, well into the 16th century. Avicenna's work built upon humoral theory, but also provided detailed descriptions of anatomy, pharmacology, and clinical practice. He made advances in pulse diagnosis, categorizing pulse types and even comparing them to musical rhythms. Ali ibn al-Abbas al-Majisi, Hali-Abbas, d. 994 AD, authored Kitab al-Maliki, the Royal Book, a comprehensive medical encyclopedia that was translated into Latin and used as a textbook for surgery in European schools. He is also recognized for his description of capillary circulation. Ibn al-Nafis, 1213 to 1288 CE, made a groundbreaking discovery in the 13th century by describing pulmonary circulation, challenging Galen's long-held theory of invisible pores between the heart's ventricles. This was a significant anatomical and physiological advancement that predated similar discoveries in Europe by centuries. Abu al-Qasim al-Zahrawi al-Birkasis, 936 to 1013 CE, a prominent surgeon from Andalusia, invented numerous surgical instruments, including forceps, pincers, lancets, and specula, and was an early proponent of using catgut for sutures. Hospitals and medical education. Islamic infirmaries were not merely places for the sick, but complex institutions that integrated clinical care, teaching, and prayer. They served as models for later European hospitals, featuring separate sections for male and female patients and often providing free services and drugs to all, regardless of financial or social status. These institutions were often funded by religious trusts or states, reflecting a moral imperative to treat all ill people. By the 10th century, laws were established to keep hospitals open 24 hours a day. The development of these advanced, secular-leaning hospitals in the East, open to all, including non-Muslims, contrasts with the more religiously focused and often limited care available in early medieval Western Europe. Pharmacology and public health. Islamic scholars like al-Ghafiqi and al-Baytar made significant contributions to pharmacology, expanding the understanding of medicinal substances. They incorporated new vegetal and animal substances from Asia, such as myrobalans, sandalwood, musk, ambergris, and new forms of sugar-based recipes, into their pharmacopoeia, which then diffused into Byzantine and Latin traditions. In public health, the widespread use of baths served as important places for therapy, purification, and cleansing for both locals and travelers. The interaction between the Islamic world and Western Europe, despite periods of conflict, led to a crucial cross-cultural exchange of knowledge. The adoption of Islamic medical knowledge, particularly from the 11th century onwards, marked a period of assimilation and adaptation in Europe that lasted for centuries. This influx of new ideas and texts, combined with the rediscovery of classical works, was instrumental in shaping the course of medical development in the West, laying the groundwork for the Renaissance and beyond. Part 3. Health, Disease, and Society. The medieval period was characterized by significant health challenges, shaped by prevailing societal structures, daily life conditions, and the devastating impact of widespread diseases. Understanding these factors is crucial for appreciating the context in which medieval medicine operated. Chapter 3.1. Daily Life, Hygiene, and Common Ailments. Daily life in medieval Europe presented numerous health challenges for all social classes, from peasants to nobility. Towns and cities, in particular, were often incredibly dirty, lacking proper sewage systems and running water, creating environments where infectious diseases could flourish. Hygiene practices. Despite common modern perceptions of pervasive filth, medieval people did engage in various hygiene practices, though their understanding of disease transmission was limited. Public bathhouses, known as stews, served the general population, while the wealthy could afford private hot water baths. Bathing was a social activity, where people would gossip, play games, eat, and drink. They used sweet-smelling oils or tallow soap, and the affluent might top and tail, wash face and extremities, multiple times a day with expensive olive oil-based soap. Hand washing before and after meals was a universal practice, regardless of social status. People also cleaned their teeth, using fresh hazel twigs as toothbrushes or wiping teeth with a linen cloth, often with sea salt and ground herbs like cloves, which were also used as mouthwash. Combs were used by everyone to brush out hair and remove parasites, with fancier two-sided combs serving as knit combs. Perfumed oils were used to keep hair from smelling between washes. Other personal hygiene tools included ear scoops, razors, tweezers, and nail tools. However, the understanding of hygiene was fundamentally different. Medieval people believed lice and fleas spontaneously generated from dirt, rather than being transmitted. While they used repellents like lavender and cedarwood, these were aimed at encouraging pests to depart rather than preventing their initial appearance. The idea that medieval people were universally filthy often stems from overly zealous Christian accounts, where some individuals chose to remain unclean as a form of religious discipline, believing excessive washing encouraged sinful pride. Public health challenges. The decline of Roman public health infrastructure after the 5th century left medieval towns with severe sanitation issues. Human waste was often thrown onto streets or into rivers and streams, which also served as water supplies. Communal outdoor toilets, or privies, frequently overflowed, further contaminating the environment. Waste from industries like butchers and tanners, including offal, blood, and dangerous chemicals, was also dumped into rivers, polluting drinking and washing water. These conditions created a perfect breeding ground for infectious diseases. Local authorities did attempt to improve public health, largely driven by the miasma theory. They fined people for dumping rubbish, banned butchers from working on streets, and in 1357, London banned waste disposal in the River Thames. New jobs were created, such as gongfirmers to empty cesspits and muckrakers to sweep streets. However, these efforts were often insufficient, as the underlying cause of disease, germs, was unknown, and the focus remained on removing bad smells rather than sources of infection. Monasteries, in contrast, were generally much cleaner, with better waste disposal systems, filters in their water systems, and monks practicing more regular washing, often due to religious beliefs about cleanliness. Common ailments and understanding. Beyond the great epidemics, medieval people regularly suffered from a range of common diseases. These included dysentery, known as the flux, tuberculosis, arthritis, and sweating sickness, likely influenza. Sexually transmitted diseases like syphilis were also prevalent across all social classes, causing skin rashes, fevers, blindness, and mental illness. Ergotism, or St. Anthony's fire, caused by a fungus on rye, led to convulsions and gangrene. Malaria was endemic in marshy regions. Infant mortality was tragically high, with estimates suggesting 25% of children died in their first year, and half of all children dying before age 5. Childbirth was also perilous for both mother and child. the understanding of these diseases was limited. Without knowledge of germs, illnesses were often attributed to humoral imbalances, divine punishment, or miasma. Treatments for common ailments were often basic. For toothache, a candle might be held to the tooth to catch worms believed to cause decay. For evil spirits, trepanning was sometimes performed. The emphasis on cleanliness and waste management, though motivated by miasma theory, sometimes inadvertently helped reduce disease transmission. Chapter 3.2: The Scourge of Epidemics, Black Death and Societal Response. The medieval period was punctuated by devastating epidemics, none more impactful than the Black Death, which fundamentally reshaped European society, its economy, and its medical practices. The Black Death, bubonic plague, the Black Death, caused by the bacterium Yersinia pestis and transmitted by fleas on rats, ravaged Europe in the mid-14th century, peaking between 1348 and 1350. It is estimated to have killed between 75 and 200 million people, wiping out up to 60% of Europe's population. The rapid and widespread mortality left people with little time to comprehend the catastrophe unfolding. Medieval doctors, lacking germ theory, mistakenly believed the plague was caused by air corrupted by humid weather, decaying bodies, and poor sanitation. Miasma theory. Recommended treatments included good diet, rest, and relocating to uninfected environments, which sometimes helped, though not for the reasons understood at the time. Societal impact. The Black Death had profound and far-reaching consequences across all facets of medieval society. Demographic and economic shifts. The massive depopulation led to severe labor shortages, which in turn increased wages for the surviving peasants and laborers. This shift significantly weakened the feudal system, as peasants gained more bargaining power and social mobility. Land became plentiful, and serfdom, already in decline, largely disappeared in Western Europe by 1500. This economic transformation laid groundwork for the development of capitalism and the rise of a merchant class. Religious and psychological effects. The pandemic induced widespread fear, anxiety, and despair. Many believed the plague was God's punishment for sin, leading to increased piety and mysticism, but also to radical movements like flagellantism, self-whipping as penance. The high mortality among clergy, who often ministered to the sick, led to a shortage of religious leaders and a temporary decline in the church's influence. Traditional beliefs about death and the afterlife were challenged, fostering an increased emphasis on individual prayer and repentance. Persecution and scapegoating. The Black Death exacerbated existing social tensions, leading to the scapegoating and persecution of marginalized groups, particularly Jews, who were often accused of poisoning wells. This resulted in pogroms and expulsions of Jewish communities from many European cities. Medical knowledge and practice. The failure of traditional university-based medicine to stop the plague led to a questioning of established knowledge and opened the discipline to new ideas. The death of many scribes meant new medical works were increasingly written in vernacular languages rather than Latin. Hospitals, previously often places of isolation, began to evolve into centers for treatment with higher standards of cleanliness and patient care. Societal response and coping mechanisms. Medieval people, while lacking germ theory, understood that disease spread through person-to-person contact and implemented quarantines. The word quarantine itself derives from the 15th century Venetian law requiring ships from plague-affected cities to wait, quarantigiorni, 40 days. Cities sometimes walled off victims or entire areas. Psychological coping mechanisms were often communal, involving liturgical rituals like processions and prayers to saints believed to have power over disease, such as Saint Roch. While some communities succumbed to fear and distrust, others, like Damascus during the plague, demonstrated a communal ethos of unity, with Muslims, Jews, and Christians praying together, which some chroniclers believed led to fewer fatalities. This period highlights a historical acceptance of widespread sickness and shorter life expectancies, where supplicating the supernatural provided a sense of control in the face of overwhelming mortality. Chapter 3. 3. Social class and access to care. Access to medical care in medieval Europe was heavily stratified by social class, reflecting the broader feudal system and economic realities of the time. This created a stark disparity in the quality and type of healthcare available to different segments of society. Feudal system and healthcare access. The feudal system, which bound peasants, serfs, and villeins to the land and required them to work for their lords, inherently limited their mobility and access to specialized care. For the vast majority of the population, the peasants and common people, access to formal medical practitioners was severely restricted. University-trained physicians were a luxury, too expensive for most, and primarily served royalty, nobility, and the wealthy elite who could afford their fees. These physicians often resided in towns, making them geographically inaccessible to those in rural villages. Instead, the low-born typically relied on local and formal care providers. This often meant seeking help from the village, wise woman, or folk healer, who possessed knowledge of herbal medicine. For more invasive procedures like tooth pulling, bone setting, or basic surgery, they would turn to the local barber surgeon. Clergymen or monks, particularly those in monasteries, also provided some basic medical care and accumulated wisdom. These local practitioners, while often skilled in practical remedies, lacked the theoretical medical education of physicians. Hospitals and charity. Hospitals played a crucial role in providing care, especially for the poor and marginalized, but their function and accessibility varied. Many hospitals were established and run by religious orders, often attached to monasteries, providing free care, food, shelter, and spiritual guidance. These institutions were seen as acts of Christian charity, embodying the doctrine that caring for the sick was a religious duty. Notable examples include the Hôtel Dieu in Paris and the Great Hospital in Norwich. However, these early hospitals were primarily focused on caring, not curing. They offered comfort, rest, basic hygiene, and hot meals, but their medical interventions were limited, as disease was often viewed as divine punishment. Patients often had to share beds, which inadvertently facilitated the spread of diseases. Furthermore, many hospitals turned away individuals with certain conditions, such as pregnant women, those with mental illnesses, or highly infectious/terminal diseases, believing they could not be helped. While some non-religious hospitals did hire physicians and surgeons, this was less common. In some cases, a well-to-do peasant or merchant might even will property to a monastery in exchange for lifelong room, board, and medical care if they became infirm. Impact on health outcomes. The tiered system of medical care had a direct impact on health outcomes. The wealthy, with access to university-trained physicians, had the benefit of more theoretically informed diagnoses and prescribed remedies, even if those remedies were often ineffective by modern standards. However, even for the rich, the success of treatments was often a matter of luck, as the fundamental understanding of disease was limited. For the common people, reliance on local healers, barber surgeons, and apothecaries meant a greater dependence on practical, often rudimentary, interventions and folk remedies, some of which were genuinely beneficial, e.g., certain herbs, while others were based on superstition or were outright harmful, e.g., unsterilized surgery. The high rates of infant mortality and the prevalence of chronic illnesses, like leprosy and tuberculosis, across all social strata underscore the overall challenges to health in the medieval period, regardless of one's position in the social hierarchy. The feudal system, by limiting access to the most educated practitioners and formal institutions, effectively perpetuated health disparities, making advanced care a privilege rather than the universal right. Part 4. Advancements and Legacy. Despite the limitations imposed by philosophical beliefs, religious doctrines, and societal structures, the medieval period was not entirely stagnant. It witnessed important advancements and laid crucial groundwork that would influence the future of medicine. Chapter 4.1. Innovations in Medical Chemistry and Pharmacology. While ancient remedies primarily relied on plants, the Middle Ages saw the emergence of medical chemistry as a distinct field, particularly around the 16th century, though its roots extend earlier. This development marked a significant step in the preparation of medicines, moving beyond simple herbal infusions to more technical processes like distillation. Medical chemistry. This field began with the adaptation of chemical processes for preparing medicines, initially characterized by the use of inorganic materials. John of Rupasissa, an alchemist, is recognized for his contributions to the beginnings of medical chemistry, particularly his work on creating the philosopher's stone, or fifth essence. His distillation techniques aim to extract a substance's purest form, believed to be its fifth essence, which could make remedies more potent by removing non-essential elements. This opened new avenues for medieval physicians to create novel and more effective remedies. Medical chemistry also led to an increasing body of pharmacological literature dealing with the use of medicines derived from mineral sources and the use of alcohols in medicine. These developments, while not revolutionary on their own, were influential in differentiating alchemy from chemistry, setting a course for future scientific inquiry. Pharmacology and remedies. Medieval pharmacology was enriched by the reception of classical medical knowledge and, significantly, the introduction of new knowledge from the Islamic world. Especially from the 11th century onwards, Greek pharmacological knowledge, based on authors like Dioscorides and Galen, was combined with Indian pharmacological lore in Abbasid Baghdad by the 9th century. This fusion led to the addition of new vegetal and animal substances from Asia, such as myrobalans, sandalwood, musk, and ambergris, into the pharmacopoeia. These ingredients, along with new forms of sugar-based recipes, steadily diffused into Byzantine and Latin traditions from the 9th century onwards. Apothecaries played a central role in compounding and dispensing these remedies, drawing from a vast array of ingredients including herbs, minerals, and animal parts. Compendiums like Bald's Leech Book, circa 900 AD, included classical citations alongside local folk remedies. The Antidotarium of Nicholas of Salerno became a standard text for apothecaries. Common herbal remedies included aloe for digestion and theriaca, a complex mixture that could contain up to 70 ingredients, including herbs and spices. The cross-cultural exchange of knowledge, particularly from the Islamicate world, was a significant phenomenon, enriching the available pharmacological tools and practices in medieval Europe. Chapter 4.2. The emergence of hospitals and formalized medical education. The Middle Ages saw the significant development of hospitals and the institutionalization of medical education in universities, laying foundational structures for modern healthcare systems. Establishment and evolution of hospitals. The establishment of hospitals was one of the most significant developments in medieval medicine. These institutions provided medical care for the sick and the poor and were often run by religious orders. Famous examples include the Hôtel Dieu in Paris, founded 7th century, and the Great Hospital in Norwich, 11th century. By 1500, there were approximately 1,100 hospitals in England. Initially, medieval hospitals were primarily religious and charitable institutions, often referred to as houses of God. Hôtels Dieu, focusing on providing comfort, shelter, and spiritual care rather than aggressive medical treatment. They also served as social institutions, offering temporary shelter to travelers, orphans, and the destitute. The care of the soul was prioritized, and patients were sometimes expected to follow monastic rules. However, over time, their role expanded. During the Crusades, hospitals became crucial for caring for the sick and wounded. By the 12th century, monumental urban hospitals appeared in Western Europe, strategically conceived to manifest the power and benevolence of administrative rulers, including clergy and kings. These institutions, while still charitable, also began to serve as centers for medical learning and innovation. After the Black Death, hospitals evolved further, becoming centers for treatment with a greater emphasis on cleanliness and patient care, moving beyond mere isolation. Some hospitals, particularly those not exclusively religious, began to hire physicians and surgeons. Formalization of medical education in universities. The period from 1100 to 1500 AD saw medieval medicine become a formal body of theoretical knowledge, institutionalized in universities. The creation of universities was a major achievement, providing a structured setting for medical study. Early foundations like Bologna, Paris, and Oxford became centers for training physicians, lawyers, and theologians. The curriculum was heavily text-based, relying on authoritative works from Hippocrates, Galen, and later, influential Islamic scholars like Avicenna. Students would attend lectures, engage in debates, and study treatises on topics such as the elements, humors, fevers, and anatomy. While theoretical knowledge was paramount, some universities, like Bologna, did incorporate anatomical dissection for teaching purposes. The development of medical licenses also emerged during this period, regulating the practice of medicine. The expansion of hospitals, in turn, provided places for the practical development of medical students, linking academic learning with clinical experience. These developments, including the creation of universities, the requirement for medical licenses, and the expansion of hospitals, represent significant inheritances from the Middle Ages that shaped contemporary medical education and practice. Chapter 4.3: Cross-Cultural Exchange and the Seeds of Modernity. The medieval period, far from being isolated, was a crucible of cross-cultural exchange, particularly between Western Europe and the Islamic world. This interaction, combined with internal developments, planted the seeds for future medical advancements that would eventually lead to modern scientific medicine. The role of cross-cultural exchange. The two worlds of West and East, despite social, economic, and religious contrasts, were not isolated. They interacted, influenced, and frequently complemented each other. Islamic medicine, building upon Greek and Roman legacies, developed extensively, incorporating elements of natural science, astrology, alchemy, religion, philosophy, and mathematics into its medical texts. This rich body of knowledge was then transmitted to Western Europe, especially from the 11th century onwards, through translations and direct interactions. Physicians and scientists from diverse origins, including India, Egypt, Greece, and the Middle East, were invited to the Islamic world, fostering a vibrant intellectual environment. This exchange brought new substances into European pharmacology, such as musk, ambergris, galangal, camphor, and sugar, and introduced new forms of sugar-based recipes. The influence of Eastern physicians like Al-Razi and Ibn Sina on the Western world was profound, with their books becoming standard textbooks in European medical schools for centuries. This vital flow of knowledge from the Islamicate world initiated a period of assimilation and adaptation in Europe that lasted for many decades, even centuries. Early forms of antiseptic practice and anesthesia. While germ theory was unknown, medieval practitioners made empirical observations that led to practices with antiseptic benefits. Theodoric Borgognoni, a 13th century surgeon, promoted early forms of antiseptic practice in wound treatment and the use of surgical anesthesia with opiates and herbs. The common practice of dousing wounds with wine also served as a form of antiseptic, an observation made without understanding the microbial basis of infection. Similarly, the use of opium and alcohol to dull pain during surgery, though rudimentary, represents an early form of anesthesia. These practical innovations, born from necessity and observation, foreshadowed later more systematic developments in pain management and infection control. The slow shift towards dissection and anatomy. Despite initial church prohibitions, the taboo on human dissection gradually lessened in the High Middle Ages. Anatomical dissection for medical purposes became more prominent around 1299 in Italy, with the first recorded autopsy dating from 1286. Universities like Bologna began to incorporate dissection into their educational settings to study and teach anatomy. High medieval surgeons like Mondino de Liuzzi pioneered systematic human dissections in European universities. While Galenic influence remained strong, leading some to try and fit observe human anatomy into Galen's, often animal-based, descriptions, the very act of systematic human dissection was a critical step towards a more accurate understanding of the human body. This slow but steady progression in anatomical knowledge, driven by practical needs and a burgeoning intellectual curiosity, was a crucial precursor to the anatomical revolution of the Renaissance. The foundations of medical chemistry. The Middle Ages also saw the beginnings of medical chemistry, moving beyond purely herbal remedies to incorporate inorganic materials and processes like distillation. John of Rupasis's work in alchemy, particularly his pursuit of the fifth essence through distillation, contributed to making remedies more potent by removing impurities. This marked the start of a differentiation between alchemy and chemistry, influencing the course of science and laying the groundwork for later pharmacological advancements. The medieval period, therefore, was not a static dark age, but a complex and dynamic era that, through the preservation of ancient knowledge, cross-cultural fertilization, and incremental practical innovations, laid many of the conceptual and institutional foundations upon which modern medicine would eventually be built. The questioning of traditional beliefs, spurred by events like the Black Death, and the gradual embrace of empirical observation, even if limited, were crucial steps in this long historical trajectory. Conclusions. The comprehensive exploration of medieval medicine reveals a field far more complex and nuanced than often portrayed. Far from being a period of stagnation, the Middle Ages were a time of gradual yet significant developments, where ancient wisdom, religious faith, and practical necessity converged to shape healthcare practices. The enduring influence of the humoral theory, derived from Hippocrates and Galen, formed the philosophical backbone of medieval medical understanding. This theory, which linked bodily fluids to health, temperament, and even environmental factors, fostered a holistic view of the patient, even if its scientific basis was flawed. Simultaneously, the pervasive influence of the Church meant that illness was often interpreted through a theological lens, seen as divine punishment or a test of faith. This perspective led to the integration of spiritual remedies, such as prayers and pilgrimages, which, while not scientifically curative, provided crucial psychological and social comfort in an era of limited medical efficacy. The Church's dual role is a critical aspect of this period. It acted as a vital preserver of ancient medical texts, safeguarding knowledge that might otherwise have been lost. However, its control over education and its emphasis on specific doctrines, including restrictions on human dissection, also inadvertently hindered empirical scientific progress. The reliance on astrological timings for treatments and the miasma theory for understanding disease transmission, though scientifically inaccurate, demonstrate a persistent human drive to find order and explanation in the face of unpredictable illness, sometimes leading to fortuitous public health benefits. The landscape of medical practitioners was diverse, reflecting the social hierarchy of the time. University-trained physicians, though highly educated in theory and skilled in diagnostics like uroscopy and pulse-taking, were largely inaccessible to the common populace due to cost and location. Their practice was often limited to diagnosis and prescription, leaving the hands-on work to others. Barber surgeons, with their practical skills in minor surgery and bloodletting, served the broader population, albeit with high risks due to a lack of sterilization. Apothecaries functioned as the primary dispensers of remedies and general practitioners for most people, drawing on a blend of herbal, mineral, and even unsanitary ingredients. Folk healers, often women, provided accessible care in rural areas, blending traditional herbal knowledge with superstitious practices. Despite these limitations, the Middle Ages witnessed important innovations. The emergence of medical chemistry and the refinement of pharmacological practices, significantly influenced by cross-cultural exchange with the Islamic world, expanded the range and potency of available remedies. Islamic scholars played a pivotal role in preserving classical knowledge and making original contributions in surgery, anatomy, and pharmacology, which profoundly enriched Western medicine. The establishment and evolution of hospitals, initially charitable and spiritually focused, gradually transformed into more medically oriented institutions. The formalization of medical education in universities laid the institutional groundwork for future scientific advancements. In essence, medieval medicine was a dynamic and adaptive system, characterized by a blend of inherited traditions, religious imperatives, and pragmatic responses to pervasive health challenges. It was a period of slow but constant progression, where the foundations for later, more significant discoveries were meticulously laid, paving the way for the eventual emergence of modern scientific medicine. Thank you for listening to this episode of Historical Podcast. If you liked it, please subscribe to the channel and watch next episodes.